Hello team, my name is Tangela Womack and I'll be your project lead. Today we're just going to go through a brief introduction of what's going to be the upcoming project. We'll talk about a few of the tasks that will be involved in our beginning stages, and if at any time you need help or there's an issue that we need resolved, remember I'm always here for facilitation within the process, and I'll be here throughout implementation. So let's get started. Our topic is the use of telemedicine or telehealth within the United States. In theory, telemedicine is an amazing service available to our patients with limited access to treatment. Unfortunately, there are some providers who misuse these services for personal gain. And we'll start with a little background information on telemedicine. Telemedicine is basically a term that was coined in 1970, which literally means just healing at a distance. The World Health Organization has adopted the following description: the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, prevention, disease, and injuries. 3 elements that are appropriate for telemedicine. Its purpose is to provide clinical support. It's intended to overcome geographical barriers, and it involves the use of information and computer technologies. Telemedicine can improve the quality of care for patients with both medical and mental health needs. A recent study showed that the patients had 38% fewer hospital admissions, 31% fewer readmissions, 63% more likely to spend fewer days in the hospital, and they were also engaged more so in their health care. Telemedicine has lots of advantages for both patients and providers. Just to list a few: they increase the access to care, reduce healthcare costs, improve patient engagement and satisfaction, and it's convenient. So telemedicine definitely has some strong points, but there are some important disadvantages also. And here's a big one: fraud. So we'll talk about a few of the most recent cases in the US. There was a healthcare fraud scheme in Florida with HealthRight LLC, where they devised a plan to solicit insurance coverage through video consults, and where they were able to provide and use private insurance carriers. They were billing for marked up prescriptions, and they billed up to $1 billion. In San Diego, there was a nurse practitioner who pled guilty for a scandal that billed the U.S. TRICARE program, which is for veterans, more than $65 million just through telephone consults. And then some owners of a durable medical company, they were giving kickbacks and bribes to other doctors who were writing prescriptions for braces following video consults when they weren't even medically necessary. And it's not always the provider or different companies. Sometimes patients misuse telemedicine as well, which leads to the overuse of prescription drugs and antibiotics. Also, patient misdiagnosis. Here is an example of 3 different clinicians out of 14 who told a patient that a nodular melanoma was benign, when in actuality, it was a pretty aggressive cancer. Telemedicine also requires that you submit a lot of pertinent information through the internet over your computer. So just as susceptible as you are to going to Target to shop, your information is also susceptible to cybersecurity. So with that information in hand, I propose that we redo the telemedicine policy, make it more standardized, because it does differ from state to state. A number of state telemedicine policies have a broad policy description and contain fewer provider restrictions on the ability to use telehealth for treatment. I propose we develop a standardized telemedicine policy that would address data security and privacy, provider specialties, and insurance reimbursement. The policy would definitely include an increased level of technology used during telemedicine services. The Centers for Medicaid and Medicare Services require that telehealth services be performed through an asynchronous telecommunication system. This is basically like a Skype or a FaceTime. It's not required that you have any type of security around it. The only requirement is that the patient is able to verify that it's actually them. There are options available that are HIPAA approved, and these options would encrypt messages, making them unreadable and unusable. It helps to accelerate the admission for emergency situations and discharges, and automatically produce a copy of the visit, which will increase accountability for providers. HIPAA guidelines make it quite clear that measures that should be used to secure patient information. Some providers choose not to do this just because of the costs associated with that technology. According to CMS, the following providers can furnish and get payment for telemedicine services. It's basically anybody with medical knowledge can bill for a telemedicine visit. I would like to implement within this new policy provider restrictions on who is allowed to bill for those services. To eliminate provider kickback and misdiagnosis, I believe we should require that physicians have an established and ongoing relationship with the patient. If there is any physician collaboration, then it should be limited to the geographical area where there is a lack of access to that relevant expertise. And then only use this treatment as an alternative to treat a patient with immediate acute care needs. There's no need to continue on with telemedicine services if the patient is able-bodied and able to come into the office, or you're in the same area for sure. You might as well just go into the office. So that will keep down on some of the misuse. And these policy recommendations are supported by the American College of Physicians. So of course, how providers are paid is a big thing. Some states require on-par reimbursement, which means doctors who have a virtual visit are paid the exact same price as an in-person visit for speaking with a patient. Medicare has proposed to pay $14 per virtual visit opposed to the $92 per patient. The virtual visits only last about 5 to 10 minutes, so $92 is a bit extreme. I propose that we come up with a system that determines reimbursement that would accommodate the provider according to their expertise and according to medical necessity. If there is an instance where there needs to be a specialty doctor, then required to be prior authorized for specialties, referrals, and collaboration. That will keep down on kickback, and it'll stop the providers from misuse and overusing telemedicine services. So just to wrap up, we've already discussed the benefits of telemedicine. We've gone over the fraud and abuse and why this policy is necessary. So in the policy development, we'll be increasing user security, we'll provide more accountability to providers, and we'll reduce the fraud and misuse on both the provider end and through the patients. So just to get started on our project, some of our beginner tasks are going to be to research the HIPAA compliance technologies that are available to providers, so that we'll have something to offer once we implement this into our new telemedicine policy. We're also going to research clinical effectiveness of each telemedicine provider type, so that maybe we can limit this to mental health or just provider follow-ups, so that it can be more effective for the patients. We're also going to research and compare telemedicine reimbursement of the key states to develop a standard payment methodology, just to make sure that providers are happy and then they're properly compensated. So that'll be all for our beginner steps in our new policy. I can't wait to work with you guys on this. Again, if you have any questions, feel free to contact me, and my contact information is on the PowerPoint. Have a good day.